Despite what the slide says, my name is Dan Fishman. Nice to meet everybody. I am a psychiatrist from the University of Pittsburgh Medical Center, and I work as part of the interdisciplinary team functioning as the Huntington's Disease Center of Excellence out there. So thank you guys all for coming. I'm really glad you guys could be here and really glad that I could be a part of something so incredible. Hopefully everybody was at the NYA talent show last night. I don't know if we have any of the performers here, but thank you guys so much. That was absolutely amazing. Woo! Yeah, well done. Not only do you guys have incredible talent, but also incredible bravery for performing up there. And as a result of that, I actually changed my talk a little bit. You guys inspired me, so thank you. All right. I do not have any financial disclosures to make. However, if anyone would like to give me some, that would be wonderful. So what is anxiety? Kind of in its most pure form, anxiety is a fight or flight response. And that means both mental and physical pieces in response to some type of stressor. Mentally, we may have a sense of racing thoughts, a sense of dread. Physically, kind of imagine, what our ancestors would have faced when kind of confronted with danger like a tiger. Now, personally, the only tiger I'm familiar with goes by the name of Tony and is more of a breakfast fan than anything. But if I was faced with an actual tiger, everything that my body does and result from anxiety is what I would want to happen. Your pupils dilate so you can see the threat better. Your heart starts racing. You start breathing more quickly. Blood goes to your muscles so you could either fight off or run away from this threat. And while this was incredibly useful in the past, now kind of our brain is kind of hijacked. It's been hijacked by anxiety. For example, you're not going to run into many tigers recently, but what you do have are day-to-day things like giving presentations, meeting new people, or kind of regular challenges where anxiety comes up because our brain thinks we're facing a tiger. The anxiety can be healthy. Being anxious about touching a boiling pot of water can be very useful, but unfortunately, oftentimes, it kind of runs out of whack. And it's especially relevant in people with Huntington's disease because of multiple reasons that we'll get into in just a little bit. And if there's one takeaway from this talk, it is that anxiety can be very overwhelming to deal with, but it is treatable and there are ways to get help. So anxiety is kind of one of the neuropsychiatric symptoms of Huntington's disease, whereas kind of the big three groups are the neuropsychiatric symptoms, cognitive symptoms affecting how we think, and motor symptoms affecting how our body moves. Regarding anxiety specifically, it often develops years before the motor symptoms, so it can be sometimes kind of one of the first signs. And unlike the motor symptoms, which usually progress as the disease goes on, anxiety is different. It starts, it stops, it comes on at kind of inconvenient times. It's not as clear-cut. One study looked at kind of where does anxiety fit with all those other neuropsychiatric symptoms, and they found that kind of the big three kind of groupings of those symptoms, apathy, which is really kind of not having the motivation to do anything, depression, your mood being really low, not enjoying the things you used to enjoy, and irritability, where you're always on edge and it just takes a little bit to set you off. Anxiety kind of falls right in the middle with irritability and depression, which really makes sense when you think about it, because both of those kind of lower our reserves to deal with stress, and that's when anxiety rears its ugly head. In Huntington's disease, anxiety is especially prevalent. It can be reactive in nature in response to kind of all the life changes that happen with Huntington's disease, and it can actually be a direct effect of the neurologic changes that happen to the brain when someone has Huntington's. Unfortunately, anxiety is highly under-researched, even more so than some of the other neuropsychiatric symptoms like depression, which is really a shame because a lot of times, like I said, it can be the first symptom to develop and it's highly prevalent. In fact, some studies found anxiety to be present in 13 to 71% of people with Huntington's disease. Now that's huge. And you may be wondering why such a wide range? Well, part of that is because of how anxiety is measured. No one can basically agree on the best way to do it. And when using the Huntington's disease rating scale, anxiety is really boiled down to just one line with three things: worries, anticipation of the worst, and fearful anticipation. And basically two of those three things are kind of the same. So based on that definition, worries, negative anticipation, or fear, how many people have experienced anxiety in their life? Absolutely. It's kind of not really helpful. So actually, a number I prefer is that over the course of a year, a full anxiety disorder developed in 12.5% to 16.5% of people with Huntington's disease, which is an increase compared to the general population, which has about 10.5% for kind of that same measurement. And actually, this number is probably an underestimate, because what's more common than a full-blown anxiety disorder in Huntington's is having traits of specific anxiety disorders. So they may have certain pieces here and there. And part of that is because it's it can be a direct neurologic effect of the disease. It doesn't follow our rules, which, kind of speaking from experience, can make it challenging for a psychiatrist to deal with because they may not know how best to clarify it, which is really kind of where it falls on kind of the people suffering from Huntington's and also family members and loved ones, because they can kind of best give the description of what it is and what they're experiencing. So how does anxiety in Huntington's actually work? Unfortunately, we don't know a lot, but what we do know is it targets part of the same brain, some of the same parts of the brain that are involved in the motor symptoms in Huntington's. Studies in actually mice have shown that the memory center of the brain, the hippocampus, is very involved with anxiety in Huntington's. And the fear center, the amygdala, is closely connected with this. This explains why some memories that are associated with emotion, especially negative emotion, unfortunately are more likely to be remembered than some of the good, happy, positive memories, or even just kind of the standard memories of, what did you have for breakfast this morning, that type of thing. So here's a scenario. Elsa's a woman in her 30s with Huntington's disease who, despite only minimal motor symptoms, worries that she is not able to keep up at work. She has discussed her status with her supervisor and has explored options for modified and decreased duties. However, even with these changes to her responsibilities, she spends most of her days thinking about her performance. And so using that as kind of a model, this is an approximate estimate of anxiety over the course of Huntington's. As we mentioned, it doesn't just increase as we go along. It actually peaks somewhere around stage 2 of Huntington's. Some of you may be familiar with kind of the 5-stage classification. I'm not going to go into too much detail about it, except I will describe stage 2, which is really where a lot of that anxiety hits. Stage 2 usually happens 3 to 13 years after someone is diagnosed with Huntington's. And part of what makes it so impairing and so likely to cause anxiety is because of the life changes that are going on in that stage. And this is around the point when people are having trouble working or maybe kind of decide to stop working altogether. And it's also the point where people are noticing some changes to how they're managing their finances and doing the day-to-day stuff around the house. So these major changes in their role in the house and independence can be hugely and very difficult to adjust to. So really kind of if those warning signs start to come up, this is a good time to intervene. Thankfully, the good news is that as people get used to these changes, anxiety does seem to decrease, which is something hopeful about the disease. So the anxiety in Huntington's is associated with, as we discussed, depression and irritability, as well as decreased quality of life, because who wants to live with anxiety like that? Oftentimes, there's changes to how someone's able to function, because when anxiety hits, it's almost impossible to think. And that can interfere with attention as well as kind of our ability to do what we need to do in life. Believe it or not, anxiety is also associated with pain. And I'm not saying that it necessarily causes pain, but one study showed that in people who had negative emotional states going on, like anxiety, depression, pain medication was 50% less effective, which is huge. And it means, kind of following that line of logic, that by treating anxiety and depression, we might be able to improve people's pain tolerance and their response to pain medication. Now, just a little bit of a warning about associations. These are not causations. So some of you may be aware that actually crime is very closely related to ice cream sales. Now, that doesn't necessarily mean that criminals love ice cream, although I'm not ruling it out. But what they think it means is that on warm days, people are more likely to commit crimes, and on warm days, people are also more likely to buy ice cream. So there's some common factor that explaining both, and right now, unfortunately, we haven't teased that out in Huntington's and anxiety, kind of where the causation is. So other things it's associated with are identifying more with the illness to the exclusion of everything else. So this doesn't mean, identifying with a community around Huntington's disease is a negative thing. It means identifying as someone who has an illness but is no longer a person or no longer part of a community is a negative thing. Not believing in treatment can be associated with anxiety, meaning that your attitude towards treatment, positive attitudes do help. Denial of illness, any extremes in anxiety is a problem. So identifying too much with the illness, but also completely denying that it exists is also associated with anxiety. And then some negative coping behaviors. Venting to the exclusion of actually progressing through and processing what's going on or what's bothering you. Only blaming yourself or disengaging, completely shutting down, kind of just walking away from the problem and pretending like it doesn't exist are all associated with anxiety. So that was a pretty long list. Thankfully, there are things anxiety is not associated with. It's not associated with age or gender, which makes it unusual, anxiety with Huntington's disease unusual compared to anxiety in the rest of the population. It's not associated with that third circle apathy that we discussed earlier. Not associated with cognitive ability, unless being so anxious prevents you from focusing on things, in which case it can affect it. Not related to the development of motor symptoms, completely separate. Not related to the number of CAG repeats that you may have inherited. And it's not related to disease progression overall. So what type of anxiety are we going to be talking about? Well, in the DSM, or kind of the handbook for psychiatrists to kind of classify diagnoses, there are many anxiety disorders as well as many disorders within the OCD, or Obsessive and Compulsive disorder spectrum. We could spend the rest of the night talking about all these disorders. You guys would miss the banquet. We'd have to order in and out. Other than that last part, it would be terrible, so we're not going to do that, thankfully. Instead, what we're going to focus on are a couple: generalized anxiety disorder, panic disorder, and a type of phobia known as social anxiety disorder, as well as OCD. So here's another situation. David is a 48-year-old man diagnosed with Huntington's disease years ago. He reports concerns about everything. He worries about his motor symptoms worsening to the point that he won't be able to drive. He has many family and friends, but feel that they're going to not respect him and not love him anymore and feel like he isn't useful if he isn't able to drive. His thoughts race for hours in bed each night, resulting in limited sleep. His neck is constantly sore from being so tense, and he started pacing during the day to try to distract himself from his thoughts, which usually end up in the same place where he's going to live the rest of his life alone and unloved because he's unable to drive. So what I just described is a typical thought pattern in someone who has generalized anxiety disorder. These are worries that become excessive, uncontrollable, and can sometimes even be irrational about kind of everyday things. It's not about something specific. The worries start off small, but then there's catastrophizing, and they kind of spiral out of control, also known as the snowball effect. These worries get bigger and bigger until they roll over everything in its path. And usually some of the things you see, and to make a diagnosis, you usually need 3 of feeling restlessness, being easily fatigued, having trouble concentrating, irritability, your muscles being so tense because you're worried all the time, and sleep disturbances, usually trouble falling asleep or staying asleep. And this anxiety, generalized anxiety, can often involve panic attacks. And this is true for people with Huntington's or true for people without Huntington's who have anxiety. So what is a panic attack? A panic attack is something that, believe it or not, 10 to 20% of the population across the board experience at least once in their lifetime. And although we don't have specific, reliable data on it, I suspect that it's even higher in those with Huntington's disease. This is an exaggeration of our body's natural fight or flight response. It's quick, it comes on sometimes even without warning, and it results in a huge amount of dread as well as physical symptoms: racing heart, trouble breathing, chest pain, numbness and tingling in our hands and feet, sweating, lightheadedness. And a lot of you may be thinking, wow, those symptoms sound like a heart attack. And that's what it feels like. Unfortunately, it can be so hard to differentiate from a heart attack that oftentimes people feel the need to go to the emergency room because they're so distressed and worried about it. And some emergency room providers kind of vary on how well they are, or how good or how well they handle people with panic attacks. Addressing the anxiety for what it is, people actually feeling these physical symptoms, even if it isn't from a heart attack, is more helpful than just writing it off and kind of invalidating what people are going through, because they really do feel like they're having a heart attack. Thankfully, full-blown panic disorder, where people oftentimes avoid any situation that gives them a panic attack to the extent that they may never leave the house, is rare in Huntington's disease. However, just having, again, those pieces of the disorder, like panic attacks, is not rare, unfortunately. So this is kind of how our body and brain kind of work together to develop a panic attack, and unfortunately, this is one of those times where I wish the body and brain weren't so closely connected. What usually happens is there's some type of trigger. Oftentimes, we're not even aware what it is, and that results in a physical symptom. Could be as harmless as our heart rate speeding up. Our brain experiences that and is like, oh no, something's wrong. What's happening? And then that triggers a whole bunch of other physical symptoms, that anxiety response that we've been talking about. And as a result, our brain sees our body going through that and is like, oh my God, now something is definitely wrong. We need to freak out. And so all of those symptoms become exponentially worse. These attacks usually peak within 15 minutes or so, but anxiety can last, unfortunately, for hours afterwards. Oftentimes, like we mentioned, the panic attacks can lead to avoidance, so you kind of never desensitize yourself to triggers, and when they happen again, it can prove just as anxiety-provoking, or if not more so than it was before. So, social anxiety disorder is a type of phobia similar to a phobia about heights, or if you're Indiana Jones, a phobia about snakes. In this case, though, we're worried about how we will be perceived in a social setting, worried what others are thinking about us, worried about how we're coming across. It can be worried about eating in front of other people, and when taken to an extreme, we may avoid others entirely because we're so embarrassed and so worried about what they're thinking. It's specifically relevant to Huntington's disease because oftentimes we can be worried about our chorea, about how those movements look to others, and early in the disease, we can be worried about talking to other people about having Huntington's. We can be worried kind of what they're going to think about us or how it may change how they interact with us. One thing I will say is that, again, taken to an extreme, this can lead to isolation and severe changes in quality of life. But here we actually have a very unique opportunity because we can kind of put this in reverse. We're surrounded by people who have been dealing with these same things for years. We can learn from them and really figure out what strategies have worked for them and how to apply that in our own life. So another scenario, a person with Huntington's disease is living in a care facility and had a serious episode where he choked on a piece of food. Afterwards, with a speech therapist's help, he could manage solid foods, although he became worried that any meal would lead to choking. He insisted on cutting each bite exactly 10 times before he would swallow it, refusing to eat it if he only cut it 9 or if he cut it more than 10 times, becoming increasingly anxious at mealtime. This is an example of an obsessive compulsive trait, which as the name suggests, involves obsessions, which are retrusive, recurrent thoughts or images that people can't get out of their heads. And as a result, that leads to a lot of anxiety. And how does our brain cope with the anxiety? Well, again, this is another instance where our brain kind of gets hijacked, because compulsions develop, which are a behavior that maybe we do once. Maybe our gentleman in that scenario cut a piece of steak 10 times and didn't choke on it. So our brain is like, okay, this is what we need to do to not have anxiety. And anything else that we do is going to lead to a lot of anxiety. So as a result, our brain gets kind of set on that track and can't move past it. And these rituals develop that must be followed exactly and can sometimes even worsen and get more severe as we go on. For example, some people have what's called contamination OCD, where they're so worried about germs, about being infected by something, that they develop very elaborate shower rituals. These rituals can take up to 4 hours. As a result, and if they're done wrong, the person has to start all over again. So as a result, it may be easier for them to avoid any anxiety by not showering at all. So therefore, even though it's kind of contradictory, some people who are very worried about germs actually will not shower for weeks, or I've even seen months, because of how anxiety-provoking the shower ritual can be. Contrast this to perseveration, which is something in Huntington's that develops as a result of the disease's effect on our brain. More specifically, kind of how the frontal lobes of our brain are regulated. As a result of the disease process, our brain starts developing rigid thinking and difficulty in switching things. This can be switching activities, this can be switching opinions, or even thoughts. And unfortunately, because it's a part of the disease, we can't really kind of talk our way out of it. It's very commonly an early symptom of Huntington's, and it's often associated with a change in functional level, so stopping work, or even changes in kind of what we can do around the house. Some common examples could be, people have residual thoughts about going back to work even when they haven't worked for 10 years. This is really more of a problem in Pittsburgh, but wanting to go outside and smoke a cigarette even though it's negative 10 degrees out and snowing. If it was negative 10 degrees out in Los Angeles, I think we'd all have bigger problems. Or kind of even things like kind of animosity or aggression towards a neighbor, even though kind of there was some slight 20 years ago, that type of thing. Compared to OCD, this is a little different. There aren't usually elaborate rituals developed, and kind of it's usually more broad than kind of the specific nature of OCD, which can show up as constantly checking that things are off or that doors are locked, or can kind of classically show up as symmetrical OCD or what's called just right OCD. A lot of you may have heard or may have seen certain shows where prominent detectives have OCD, where everything has to be a certain way. Well, sometimes just right OCD can show up a little bit differently. I'm no art major, but even I can tell that those lines don't add up or don't line up. However, if someone has OCD, with this orientation, it may give them that feeling of things are just right. And so they might want things in their house to be a little bit off just like that, because that's what calms their anxiety. It isn't really apparent to someone who doesn't have OCD, and we don't really understand quite how it develops. So that was a whole lot about the anxiety in Huntington's and anxiety in general. Now we're going to get into what we can actually do about it. So unfortunately, as I mentioned, anxiety in Huntington's is very understudied. There have actually only been 5 studies looking at effective interventions. Thankfully, 3 of those studies did show positive results. A medication called olanzapine that we'll talk about in a little bit was shown to be effective. A participation education program for those with Huntington's disease, which involved 90-minute biweekly studies for about 8 sessions, where people learned how to look up information about anxiety, look up information about Huntington's, and kind of how to cope with what they found, as well as intensive short inpatient stays at an inpatient like rehab hospital. Sadly, many of those studies, or actually all of those studies, had very low numbers of participants, no control groups, and used different outcomes to show whether they were successful. Now, I know a lot of you may be thinking, well, what do we do if we don't have access to, an inpatient rehab hospital or these type of programs, because 99% of the country does not. Well, thankfully, there are some things we can do for anxiety that help whether we have Huntington's or help whether we don't have Huntington's. And these are usually called distress tolerance tools. The reason I put a giant picture of a building up there, especially one that's curved, is because if I was on the top floor of that building, I would be having a lot of anxiety right now. And not only that, but if I experienced an anxiety spike, it would only take a little bit to send me through the roof. That anxiety would be gone. And anxiety is much easier to prevent than it is to control once it's already there. So if you can do something throughout the day or calm yourself when anxiety first starts, that kind of brings you back down to the ground floor of that building. And then you have a lot farther to go if you do have a spike before you go through the roof. So an easy kind of way to remember it is that, believe it or not, anxiety is temporary. Anxiety spikes are temporary. And so good thing to remember goes by the mnemonic of temp. The first one is temperature. That fight or flight response that we experience, cold temperatures can actually help reverse that. A lot of what we talked about previously was our brain tricking our body into showing physical symptoms of anxiety, tricking our body into thinking we're having a heart attack. Well, now we finally get revenge. We get to do things that trick our brain into thinking we're not anxious, and cold temperatures is one of them. Even just putting a cold rag on our face for a couple minutes has been shown to slow heart rate. And actually, they sell blue ice packets that are bendable. You can cut them up into a shape that you like, put them in the freezer overnight, and they're there in the house when you need them. If you start feeling anxious, take them out, put them on the back of your wrist, the back of your neck, wherever kind of you find helps you. And that's actually been shown to help decrease anxiety. Another great way to distract yourself from anxiety is exercise. Whether that's going on a walk, whether that's going to the gym, whether that's even dancing at the banquet tonight. Exercise does help distract yourself and actually produces some helpful endorphins that can combat anxiety. You basically kind of work that stress off and bring yourself to a lower floor of the building. I'm going to skip muscle relaxation for a second and talk about paced breathing. You guys may have heard this by a lot of different names. Yoga breathing, deep breathing, diaphragmatic breathing. The reason there are so many names is because it's universally accepted as a way that can help anxiety. So many of you know, people say breathe in through your nose and out through your mouth. That's actually not the most important part. You want to breathe through your abdomen, not have your chest rise and fall like it normally does. The reason for this is because there's a nerve that runs along our diaphragm called the vagus nerve. And this nerve is the same one that's activated when we eat a large meal. I don't know what everybody had for lunch, but I do know after Thanksgiving dinner, I get incredibly tired. And part of that is because that large meal is activating that nerve. So by actually breathing through our diaphragm, we can do the same thing and activate the same nerve. So how it works, kind of the best way that I've found is, at least when you're starting out, to keep your hands on your stomach so you can physically feel your stomach, your abdomen rise and fall, not your chest. And when you breathe in, whether it's through your nose or if you're congested through your mouth, breathe in for maybe 3 seconds, hold the breath for 4, and then breathe out for 5. Breathing in, your stomach will expand, and then when you breathe out, it'll contract. Again, the exact number of seconds is up to personal interpretation, but the important thing is that you're breathing through your abdomen, and a lot of times when you do it, you can actually feel your heart rate slow down. And this is most effective when it's paired with muscle relaxation. And what I mean by muscle relaxation is, while a massage can do wonders, this is something that you can do on your own. It's actually tensing up a muscle, like making a fist, holding it as tight as you can for a couple seconds, and then letting it go. And so if you pair that with breathing, clenching the muscle while you're breathing in, holding it while you hold your breath, and then as you let the air out, relaxing that muscle, that can be incredibly helpful. I recommend starting with the feet, working your way up the body to your neck, and then down your arms, so ending with your fists and kind of letting that anxiety flow out of your body. So those are some things you can do either throughout the day to bring yourself to a lower ground level of anxiety, or when you're in the midst of an actual anxiety or panic episode. Some of the things that you can do, changes to your house or that loved ones can do to help make things easier on us, include minimizing clutter at home. You may have heard the phrase clean house, clean mind. Believe it or not, if things are around the house, things you have to constantly focus on, it actually does cause anxiety. The more thoughts we have running through our head a lot of times, the more easy it is anxiety for kind of break its way in. It's important to establish regular routines and stick to them. I read once that it takes about 40 days of doing something repetitively to build a routine, to actually ingrain it, and it's much easier to break routines than it is to build them. It takes hard work to train our brain into doing something and to considering it normal. However, if you can, this will help fight that perseveration. If your brain knows what's going to come next, there'll be less anxiety with transitions. Again, keeping requests and questions straightforward. Since cognitive symptoms are so prominent in Huntington's, kind of being told a dozen things, like no matter kind of what stage you're at or no matter who you are, like I'm not going to remember half of those. And as a result, we're going to get anxiety because we know there's something we forgot and it's going to work us up and we won't be able to get it out of our mind. So therefore, saying things one at a time, breaking requests down, or chunking, as it's called, can be incredibly helpful. Sometimes people will perseverate on events for days leading up to it. If you know that's kind of how you deal with something, have people, not tell you things until the day of, especially if it's something anxiety-provoking like a doctor's appointment. If you don't need to know, then you don't need to know. Or do the exact opposite. Because some people find that if they are surprised with things, or if something kind of comes out of the blue, then they get very anxious. And for those people, maybe it's better to slowly introduce an idea over days, again, kind of expressing one idea at a time to help people get used to it. And then, since changes in routines can be so devastating and so anxiety-provoking in Huntington's, plan ahead for changes by increasing support or doing them gradually can make all the difference. And then, although there's many types of therapy that can be very helpful in Huntington's, the one I want to talk about is cognitive behavioral therapy, or CBT, because that's something that people can actually do on their own or with the help of loved ones. So the main idea of CBT is that thoughts, emotions, and behaviors are all connected. And that can be a positive thing, or unfortunately, it can be a negative, because sometimes we have automatic negative thoughts. For example, even walking up to the podium, I was thinking in my mind, oh no, what if people don't like the talk? What if everyone in the whole room falls asleep? How am I going to wake them up? What do I do? And those are just normal thoughts. However, again, they can be taken to extremes where they start influencing our emotions and our behavior. So for example, let me give an example. Some of the wonderful stars of last night may have been worried people aren't going to like my singing at the NYA talent show. And if you have a thought like that, it's going to lead to anxiety, which can then often result in the ostrich defense. You bury your head in the sand, you don't go to the talent show, you run away from the anxiety, and as a result, what that does is actually reinforces that negative thinking because you never disprove yourself. And then when next year rolls around, you're like, oh my goodness, I had so much anxiety last year, this year's going to be even worse. It's going to be even harder to sing at next year's talent show. So again, I'm so impressed with everyone who performed yesterday because they found a way of breaking this thought pattern, which is called behavioral activation. Even though every fiber in their body may have been screaming, we got to get out of here, don't do this, they did it anyway. They performed and they were absolutely incredible. But believe it or not, an easier place to intervene is actually at the thought level. For example, very common in Huntington's disease are worries that I won't be able to be helpful around the house, and similar things along those lines. Even just reassuring yourself or having loved ones reassure you, it doesn't matter what other people think. Your family knows that you're helpful and your family knows that you are loved, can be incredibly important in breaking a thought or anxiety spiral like this. what you should do is try to find out those negative thoughts that are there and then challenge them by one of two ways. One, are they true? That's kind of in the case of, my family's not going to love me, or I'm not helpful around the house. Or some of our worries are true. And in those, for example, people may be worried that HDSA is going to end shortly, and that's going to be awful. I won't have anything to look forward to. Well, while it may be true that HDSA is going to end shortly, those thoughts of anxiety about it could take away our enjoyment of the moment and of the banquet tonight. So those thoughts aren't useful, and it's better to just put them aside in our mind until we have a chance to examine them later. And these negative thoughts or thought distortions can show up a lot of ways. Automatic negative thinking, or automatic all or nothing thinking, where things are either black or white, even though we may be looking at something that's gray, jumping to conclusions, mind reading, guessing what other people are thinking, even though half the time I don't even know what I'm thinking. As well as the fortune teller effect, predicting the future even though there's no way we have no way of knowing what's actually going to happen. And then I want to spend some time talking about pharmacotherapy or medications. And the reason I have pictures of keys and locks up here is because that's how most of the medications in Huntington's disease works. Our brain, the neurons in our brain, have certain receptors or locks that respond to certain chemicals produced by other neurons or certain keys. And these thousands and millions of chemicals and locks are hanging out in our brain, and the medications we have for Huntington's disease to affect anxiety, what they do is they act or they change how those keys fit into those locks or change the number of available keys and locks. So in the picture over here, the blue blob and the green blob are both neurons. And hopefully everyone can see those little Tetris-looking blocks that are floating in between. Those would be the keys. Those are chemicals that the neurons are sending out. And then down in the bottom left, there's this blue box with a Tetris-shaped hole in it, which is one of those locks that the keys are looking for. And when they bind onto those, when they connect, those neurons are going to fire. And that controls things like depression, anxiety, and a whole host of other things. So what some of the medications do are change the number of available keys. They stop the molecule that chews up those keys and actually increases the number of available keys. Those medications are traditionally called antidepressants, although I hate how we label medications because they're also excellent for anxiety. If we had to compare it to a boat springing a leak, antidepressants is the equivalent of taking the boat to the shop and getting it fixed right. It's going to take maybe weeks to do the job, but when it is, you're actually fixing what's wrong. Some other medications that we'll talk about later do things a little bit differently. So a lot of the antidepressants work, the selective serotonin reuptake inhibitors work by increasing the keys that are serotonin. That's one of those chemicals that the nerves secrete. Other antidepressants affect both serotonin and norepinephrine, so increasing multiple keys. And then some are kind of outliers and actually change how effective keys are at turning in locks. There are some medications, antidepressants, that affect even more keys or more chemicals like dopamine, but those tend to have some increased cognitive effects in Huntington's disease, and so we tend to kind of stay away from them unless we absolutely have to go there. Benzodiazepines are medication that's kind of equivalent to bailing water out of the boat. It's not going to fix the underlying hole, but a lot of times it's a short-term fix that'll at least get you through until those antidepressants can kick in. There's short-acting ones you take multiple times a day, longer-acting ones you can take once a day, or sometimes even twice a day. And as a result, they're often very commonly used in Huntington's. Unfortunately, all medications do have side effects. For example, the antidepressants can have side effects of changing sleep patterns, sweating, headaches, and these medications can have side effects. The benzodiazepines can have side effects of increasing falls, even changing our memory as we get older, and unfortunately, the longer we use them, the more addictive they are. That's why we tend to use these in kind of the much shorter term, only using them long term if we absolutely have to. And then there's another group of medication called the neuroleptics, which basically work by blocking a certain type of lock that responds to dopamine. These medications do a ton of different things. Decrease irritability, oftentimes actually help with chorea, help with anxiety, can boost antidepressants, but they're more famously known by their other name, which are antipsychotics. And again, this is why I really don't like how we name medications, because these medicines do so much more than just that and have a very negative stigma as a result. And while they do have side effects, which can be anything from making people more stiff or more rigid to actually increasing anxiety in very small or rare cases, thankfully those side effects are pretty rare. And a lot of the side effects that we have kind of observed are using these medications in doses for psychotic symptoms, not for anxiety. We usually use much lower dosages. So there are some other agents that work through histamine. You can actually buy over the counter, things like Benadryl. There's beta blockers like propranolol, which can kind of decrease the arousal from that fight or flight response that gets so prominently enhanced by anxiety. And even anti-epileptics, things like Depakote or valproic acid, can actually help with anxiety and Huntington's disease. So again, no anxiety or no medication is without side effects, unfortunately. Even some of the ones that we so often use to help with Huntington's, xenazine, Austedo, also have side effects, which can rarely, in the range of kind of 5 to 15%, actually increase anxiety. So again, anxiety can be from a lot of different causes, which is why kind of honest communication, a two-way open communications between people with Huntington's and their doctors is so important, because I don't think either can do it alone, but together they can have a huge impact on decreasing anxiety and a huge benefit to quality of life. So thank you guys so much for your attention, and I'll leave you with the quote I enjoy. Anxiety is like a rocking chair. It gives you something to do, but you don't get very far. Thank you so much. So we have about 15 minutes for questions. Someone very generously offered to walk around with a microphone if you guys have questions, and I'll open it up.
On the medications that you put up, are those just for people with HD, or is it for all?
Excellent question. Thankfully, those medications are actually for everybody with anxiety. Again, I really wish we had more studies specifically in Huntington's. The one that has shown to have benefit is the olanzapine, which is in that neuroleptics category specifically for anxiety with Huntington's disease. In the front?
The difference between depression and anxiety.
So for those watching the video, she asked what the difference was between depression and anxiety. And that's been debated for a long time, and the answer depends on who you ask. So much so to the point we used to kind of consider something have a diagnosis in anxious depression because those symptoms go hand in hand. How I tend to differentiate it is anxiety is something that causes racing thoughts or a sense of dread, oftentimes associated with physical symptoms, whereas depression is more associated with decreased mood, not enjoying things that you used to enjoy, senses of guilt, hopelessness, even to the extent, that over long periods of time, people actually may develop suicidal thoughts or wish they were dead.
And if that's different. And is that different medication indicated between the two?
Thankfully, a lot of the medications actually work for both. I'll go back to that first medication slide. All of the medications on here actually have been shown to have some efficacy in treating both to various extents. Some of the other ones, like the benzodiazepines or some of the neuroleptics, are usually better for one versus the other, oftentimes for anxiety.
you spoke about the antipsychotics, I believe, or
Yes.
neuroleptics. What's the difference between those and psychotropics?
Another great question. Psychotropics, at least currently, is what we use to describe any medication that really has an impact on those neuropsychiatric symptoms that we kind of first mentioned, the anxiety, depression, apathy, irritability, psychosis, whereas the neuroleptics is a specific term for medications, classes of medications developed to be antipsychotics, but then we actually found afterwards that they have a whole lot of other benefits. So psychotropics is the big category, and neuroleptics is a smaller part of that.
Okay. My spouse has Huntington's.
I see.
He was recently sick, and they adjusted his medications, and they were also treating him very differently from the place where he's staying now, where they were treating him very nicely. And he seemed to reset back to almost a year ago in his Huntington's. It was great to see.
That's wonderful.
But, I'm wondering, part of what they were doing in the adjustment of medications were they were giving him a pain medication where he had absolutely not said anything about having any pain. But it seemed to help in some way. Now, from what I understand, people with Huntington's have a diminished awareness of pain.
So it's, without knowing exactly what medication, it's hard for me to say a
They
little
were
bit.
using gabapentin, and it had I think, an off-label use for the anti-anxiety. But he does have diabetes, so they use it for that, but I didn't think that he had any neuropathy.
Neuropathy? Yep.
Yeah.
So again, or not again, but absolutely, gabapentin is one of those where kind of the anxiety effects aren't as clear, but that would kind of fall under that anti-epileptics category that is thought to potentially have some impact. And part of a symptom of Huntington's is that apathy, which can be decreased kind of awareness of changes in mood, decreased interest in what's going on, but also sometimes decreased awareness of pain. And so it's possible that, there was a pain component that was affecting him, kind of affecting his mood or affecting his anxiety level. But again, because of the disease, it wasn't at the forefront of his brain and he wasn't as aware of it.
This is just my own little theory, but I was wondering if he's having trouble perceiving what's going on, and that's adding to his anxiety. He's unable to find the words to describe it, and he substitutes words, and even though it's the wrong word, that's how it gets filed.
And it's certainly possible. Yeah.
Okay, so what I'm doing there is just trying to be clear about what is actually going on, saying this is what's happening, being predictable.
And I think that's exactly the right thing. Again, kind of making things as kind of most straightforward as possible. Again, kind of decreasing the clutter of the mind, expressing information in kind of easily digestible chunks is going to be very helpful. So I'm glad that you're doing that for him.
Well, I know this is going to be kind of hard to answer, but do you have any guidance on, there's this laundry list of medications, and as you go, do you just talk to the doctor and let them pick one? Do you have any, what kind of guidance or suggestions would you give on what type of medication to suggest? Because I know, for instance, with my sister-in-law, my mother-in-law is very concerned about, she's on this medication for her anxiety, and she becomes like a zombie. It's I don't know what she's on, unfortunately, but how do you choose?
So we could probably talk for a full hour about that. I will try to kind of condense that down, because I'm glad you asked that, because that is a huge issue that many people face. So usually kind of based on specific symptoms, and again, I don't think it should necessarily just be the doctor deciding. I think it should be kind of both of, again, two-way street, with the person with Huntington's and family working with the doctor, because the things that factor into that our class of medication. If there's kind of depression going along with the anxiety, then maybe an antidepressant would be most helpful. If there's movement chorea going on with it, then maybe a neuroleptic that can hit both of those would be most helpful. If it's just rare, kind of once a month anxiety spikes, then maybe a short-acting benzodiazepine, so they're not on medication the whole time, is what you need. It kind of depends on the situation. The way I tend to break it down are, do they need a longer lasting medication, or do they just need to take medication for anxiety as needed? If they need to take it as needed, then we're looking more at the benzodiazepines or neuroleptics. If they need to be on it long term, then the antidepressants are usually a good place to start. Often the SSRIs, selective serotonin reuptake inhibitors, because they have the best safety profile. And that's really kind of where it comes down to it. We try to pick medications that are going to treat symptoms, and the side effects are either going to be the least or actually helpful. There's some medications that increase sleep, increase appetite. Oftentimes at the end of Huntington's disease, appetite can be a big factor, so maybe that's kind of a good choice. It just kind of depends on what they're going through. And I'd be happy to talk to you afterwards if you can have some specific questions about that.
Thank you.
Absolutely.
For the caregiver, how do you deal with a situation where there's a rapid mood change resulting in extreme anger over a non-issue?
So if I think identifying a trigger can be huge. Sometimes there may not be, but whether that trigger is a specific thought, a specific event, kind of figuring out what led to that increase in anger is so important, because prevention always easier than treating it kind of after the fact. Sometimes, again, kind of leaving the situation if it's escalating to the point where kind of safety is a concern is very important. And if this is happening regularly and behavioral or environmental changes aren't cutting it, then at that point I would maybe consider a medication to take as needed to kind of when things start ramping up, so that kind of we can stop it from getting to that point.
Also, as a caregiver, how do you deal with OCD behavior where your spouse or whoever is affected gets fixated on something, and it seems like you can't or they can't move forward in their day until this is either resolved or till it's resolved. How do you deal with that?
So OCD behaviors are very challenging to deal with. They can be incredibly impairing. And part of what makes them so challenging is it can be difficult to differentiate whether it's kind of classic OCD or more perseveration from the Huntington's itself. If it's more along the lines of OCD, then that actually responds to one of those keys, the serotonin key, but in much higher amounts than things like non-OCD anxiety or depression. So in that case, we actually need very high doses of antidepressants that affect serotonin, especially the selective serotonin reuptake inhibitors, and that actually can oftentimes decrease that behavior. If it's more due to the perseveration, then sometimes the antidepressants may have a benefit. Oftentimes we may need a little bit of those antipsychotics or neuroleptics to kind of help move past that.
I guess as a young caregiver, do you have any advice on how to get like a parent or someone with HD to even consider medications? Or in my case, my dad was on them and felt that foggy feeling, so he never wants to go back. Any tips on just kind of getting through some of those steps?
Yeah. So I think when people have had a negative experience on a medication, it's very common to be concerned about all medications because they don't want to go through that again. I think telling them, reassuring them that there are different types of medication that don't have that effect can be important to hear. And actually using those CBT, those cognitive behavioral therapy techniques, Because believe it or not, that is kind of a negative thought. That response to one medication, it means I'm going to respond that way to all medication. This group is another great example or another great opportunity for helping with that. Talking to people who have had success on medications like that, seeing evidence that they don't always create that foggy feeling can be really important. Yeah.
I just have a quick question. It kind of goes along with both of these ladies, and so I was like, oh, good, we kind of hit on it. But I have a dad that's in late stages of HD. He's in a care center, and I would say he's more on the psychological end. He actually has no movement disorder at all right now. But one of the things he does tend to do, just like you talked about, is he has a really big problem with perseveration, and he has one sentence in particular that he likes to repeat to me, and I can tell that he is very anxiety-ridden when he's saying it, and so I've tried everything, like as far as turning the radio on with really calm music, and sometimes he'll start humming that tune instead of the same sentence over and over and over again. Is it something I can do for him, or is it his medication needs to be adjusted because something is off?
And realistically, the perseveration is very hard to treat, either through medication or through behavioral, environmental therapy techniques. Sometimes those distress tolerance skills can be helpful, because if he can latch on to doing the paced breathing, perseverating on that, then that can actually kind of help calm him down as he continues to do it. But it's kind of like, running a race. You just don't kind of walk out the door and run a race. It takes training. And so by training yourself to do that, to kind of reinforce those brain pathways, can really help kind of fight that. Yeah. And I think that would apply to your question as well about the OCD behaviors. If you notice that anxiety is a big component of those repetitive behaviors, then sometimes those distress skills can kind of help prevent it from getting to that point also.
Could you please speak a little bit about pharmacogenomics?
So with regards to anxiety, pharmacogenomics, basically what she's getting at is kind of personalized medicine, adapting kind of medication based on specific, genetics per person. And unfortunately, kind of in the psychiatric realm in general, but especially for anxiety in Huntington's, we aren't really there yet. We do know that certain medications are metabolized based on enzymes, chemicals in the liver, and there is some genetic component to kind of what amount of enzyme we have and kind of how much of each of them, which may determine whether we have a response to medication, whether we may need a higher dose, whether we're more likely to have side effects. The studies for that aren't really ready for prime time yet to show whether it makes a big difference in treatment, but it's just something useful to keep in mind, because kind of people may need lower or higher doses of medication, and really the best way to figure that out is adjusting the dose kind of in close conjunction with a doctor and family members providing input on what symptoms and what effect that's having. Did that kind of answer your question, or were you more wondering about? Okay, thanks.
So my question is, with somebody, my husband was recently diagnosed, and his irritability has just jumped over the past few weeks, and he never really wants to take any meds. And I'm learning from the different workshops here that aside from me suggesting that he takes something because of his irritability, because he feels completely justified, when I even tell him what he says, he tells me why that's right. Or if I tell him nobody else, I'm like, nobody else should put up with this, nobody else talks to people like this. He says, I just can't take it. So I will, of course, talk with his doctor, but can you kind of give me some other hints as how to, or if I should approach him, or if I should just go directly to the doctor and let them do the talking to? But the thing is, then he'd get mad at me for telling them. So I'm in this evil circle of can't do anything right kind of thing.
And that helplessness is unfortunately very common in this situation and can be so impairing for family members and loved ones and caregivers, because we don't want to go behind our loved ones' back. We want to respect their wishes, and at the same time, we also want to help them deal with symptoms that because of their disease, they may not be able to see. So that is just across the board too big a burden for any one person to bear. It just, unfortunately, we get put in that position, but I think reaching out for help is very useful, whether that's kind of touching base with with his doctor, and asking for some time at the end of the session, kind of for just you and him to discuss, and maybe suggesting that it be the doctor's idea so you don't get the blame, I think can be very helpful. Emailing, sending kind of symptoms so the doctor knows ahead of time what symptoms to target can be very useful. As well as, I don't know if they'd be willing for this, to do this, but to see a therapist or someone who kind of could suggest these things so they're not coming from you. Because sometimes loved ones are so close that it can be hard for us to hear what they're saying, and having a neutral third-party person can be really useful in kind of breaking through some of those defenses that we build. Yeah, welcome. So I think we're out of time. Maybe one last question. Would that be all right? And I did see you raising your hand. Yeah.
I just had one comment that's kind of related to the last few. I think it's really important to have that conversation with the doctor or the whole team of doctors and say, please allow time separately for us where you can talk to them separately, maybe your loved one can talk with them separately, so that you can have those conversations and not have it be like a conflict in the office. Because when I've taken my wife to the doctor and she says everything's fine, and like it's like 5 minutes and we're gonna be leaving, and I would say, well, it's not exactly fine. Then it turns into like this ugly situation. So yeah. She's changed doctors, so I had to have this conversation twice with two different teams of doctors, but they've been very good about trying to arrange somehow where you're separate, and like just asking one or the other to leave the room. We just want to have that kind of a thing. I think it's very important. And my wife was prescribed Buspirone the last time. Mm-hmm. In addition to she's on Cymbalta, but she hasn't. She won't let me fill the prescription. So these are not easy conversations to have in front of her. So you kind of have them with the doctor outside of that, I guess. So.
An excellent suggestion. I completely agree. That's information the healthcare team needs to know, but it doesn't necessarily have to lead to conflict with loved ones. Yeah, great idea. Well, thank you guys so much for coming out. Really appreciate you being here. Thank you.